I hope this is all visible to you now. I work at multiple institutions in the Netherlands, like the National Institute for Health Services Research, the National Psychotrauma Center, the Institute for Physical Safety, the National Institute for Public Health and the Environment, as well as Groningen University, where I have a special chair in crisis, safety and health. And as you can see, what you can see on this first slide is that a few of the cases that my organizations and myself have been involved in the last couple of years, varying from the fireworks explosion in Enschede, the shooting in Utrecht in 2019, of course the gas mining dossier in Groningen, which we are assessing the psychosocial impact together with the Groningen colleagues, of course, and recently we had another report published. MH17 disaster, industry, because our country is filled with industrial sites that can cause serious health risks. And in the end, the last picture is from COVID-19, of course, which is the most recent large-scale crisis that has confronted many countries in the world, including the Netherlands, with many challenges. And as you all, we are only recently in the opportunity to start learning what COVID-19 really means for us and what we can learn from it, also on the longer term. And most of my work is about understanding the effects and the risks linked to exposure to events like these. What do they mean for the social tissue? What do they mean in terms of mental health effects, but also physical health, chronic illness? So in a way, how is the health and well-being of people and the safety affected by exposure to crisis? And the more important question probably, how should we respond as a society, as governments, as civil society actors, as citizens ourselves to events like these? My presentation of today really focusing on the mental health aspect, which in the scientific literature is often called mental health and psychosocial support, MHPSS. And what I really am interested in is whether everything we have learned in recent years about MHPSS, mental health and psychosocial support, the evidence base we have, the knowledge base we have, to what extent it's really applicable to a crisis like this, which is really a different type of event compared to earthquakes, terrorist attacks, flooding. And so I prepared this talk for you, and it's divided in 3 parts. And the first part is revisiting the current disaster mental health knowledge base we have. What do we know about the epidemiology of disasters, the effects for human beings, and the guidance that is available internationally, the documents we make with recommendations and principles on how to act in times of crisis on behalf of mental health. That's part 1. Part 2 is really focusing on COVID-19 and what do we know, or what do we expect about the mental health impact, I should say also, because it's only fairly short that we are in the pandemic. It's definitely too short to say anything about long-term effects, especially also because the pandemic is still evolving. So what was done so far in different countries? What can we learn from evaluations? And in the end, I want to close with a third part, which I call reflections. And this part is really about answering the question whether our knowledge base is applicable to a crisis like this. And when I'm ready, then we can, of course, proceed with our discussion, Rónán. Existing knowledge base. There are tons of literature on the impact of disasters on societies, on people, on populations. If we really make a short summary of that we can only conclude, which is very obvious and very clear, dominant, available in the literature, that exposure to disaster and environmental hazards combined with additional stressors linked or not linked to the original exposure is not good. It is accompanied by a probable increase in post-traumatic stress disorder, mood and anxiety disorders, substance abuse, dependence, suicidality, physical symptoms and conditions, and social problems. There's a massive literature about these topics. What we also know about when it comes to the pattern over time, that the dominant pattern is one with a sharp increase in the first period of months that surely decreases in the first 1 to 1.5 years. And the dominant view in literature is that if at a certain moment it stabilizes at a somewhat increased level than it was on beforehand. At the same time, disaster studies have severe methodological problems mostly. Many studies don't have a pre-event or a baseline to consider, lack the right probable useful comparison groups, and there are various sources of bias linked to measurement error, and also the fact that questionnaires also have a tendency of over-representation of vulnerable, I should not say vulnerable groups, because they are mostly not present enough in the data, but also in an over-representation of self-reported mental health problems. Also because people who are really more interested and feel more people who are more interested in mental health issues and take them more seriously are also more probable to participate in surveys. We also know is that baselines differ across countries. There are multiple large-scale epidemiological studies that show that baselines in different countries that can range from very little up to 10%. And so you should be aware of that before you start interpreting what the effects of a particular disaster could be in a different society, especially because we also know that these baselines are also linked to the degree of trauma exposure in a country and cultural and socioeconomic country characteristics. This is one actually of my hobby studies. I'm really interested in the extent to what we can explain differences in, for instance, PTSD prevalence or depression in different countries and how this is linked to culture. What we know is that especially less vulnerable countries that score good on governance, access to healthcare, life expectancy, these countries are also more populated by individualistic populations, have a lower power distance. We call these countries less vulnerable from a disaster risk reduction perspective, but we know that these populations in these countries, paradoxically, have a higher risk of developing PTSD, depression, suicide. And so in the end, that's what we call the vulnerability paradox. That also plays a role at the background of interpreting epidemiological research. What we know about risk and protective factors is that, well, there are multiple factors that play a role in the development of mental health problems that affect well-being. And we know that they differ in different time stages. So in the pre-event phase, we know that gender, age, ethnic background, socioeconomic status, earlier exposure to traumatic events, and existing health problems are also risk factors for developing new problems in a disaster. During the disaster, in the acute phase, if you would call it like that, the level of exposure matters. That can be either physical, but it can also be more perceived. Exposure to death and destruction, the fact that you lose those things that are valuable to you, and the geographical remoteness of the exposure, all these things that can play a role in the development of health problems at a later moment. And then we have the recovery phase, where actually the society is starting to return to its normal pattern. In that phase, people can also suffer from additional losses and new sources of stress. For instance, the fact that you're being separated from loved ones, but also that you run into relation problems or problems at work that can also get worse later on. And we know that the later part of the recovery phase, that's in literature sometimes called disillusionment phase. That's a typical period there. The honeymoon in the beginning is over, and you don't get a special treatment anymore, and everyone else in the world takes up their normal business, but you are still there with all the misery you have experienced since the disaster, and the fact that your life is not changed in the way you want it to be at that moment. So these are risk factors that play a role. Risk factors can also differ at different levels. We have individual factors. We have also factors that form a risk at the community. For instance, that the social tissue and cohesion are damaged. That also the fact that in some disasters people are forced to live elsewhere. So original support reservoirs in a community are not available anymore. It can also be the case that the local community is not able to make the necessary changes to turn back to normal. And then we have societal factors that play a role. Some countries are better equipped for the recovery of a disaster than others. Guidance, that is also an important part of our knowledge base. The last couple of years, a lot of time and efforts have been made to develop guidelines and other standards. And the idea is that you combine scientific evidence and practical wisdom into practical documents that can actually help us to deal with the impact of new events. In the Netherlands and other countries, we have those guidelines. They contain ideas, principles, recommendations. They do have limitations, but experience so far reassured us that they are undeniably valuable as a frame of reference when disaster strikes. This slide contains a lot of information, but the most important thing is an overview of internationally available mental health and psychosocial support guidelines that we rated with multiple raters to assess the quality and be used, as you can see on the right column, the agree instrument, which is comprised of 5 dimensions. The scores can range from high to low, with higher scores indicating a better quality. And what you can see in this slide, I think the main message is there's a lot of variation in the quality of guidelines, which is also important because that means in the end they serve the same purpose. They are designed to help us with planning and implementing services for affected populations, but the level to which they are actually helping us depends also on the quality of the documents. This paper is currently, we had very favorable reviews and are working on resubmitting it, so I have good hopes that I can send everyone who is interested the final copy in the nearby future. This is from a company paper. This is where we analyze the quality of the guidelines. And we worked with the 4 guidelines with the highest quality scores. And this is also a slide, you don't have to read everything, you don't have to, every element of it, you can forget it. But the most important message here is that you can divide the contents in multiple categories. So there's one part of the recommendations is really about basic relief, about basic services everyone affected after disasters should get access to, like shelter, food and water, hygiene, and also about information about what is going on, information about where you can go for assistance, about how the planning of the recovery proceeds, and what you can do yourself, even your health risks and what you can do about it. Then we have the emotional and social support category. And we know that every disaster has an emotional and social impact. We also know that support in your nearby community from peers and loved ones, but also from governments, is crucial because this support is protective against the development of all types of mental health problems. And it's also a part of recognition and acknowledgement. The fact that your problems are taken serious is also reflected in the level of support that you receive from actors in your environment. Practical support is a category, help with your household, financial issues, legal issues. Many disasters are followed up by legal issues, and that means that people are suddenly confronted with complex processes which are very difficult to find your way in. This is also something we see in Groningen, for instance, in the gas mining crisis, that we have this plethora of arrangements and people can use them, but it's not easy to find your way in there. So support is welcome, and it's also, if it's not there, it's a stressor. Then you have professional healthcare. For those people who are at severe risk, already have developed problems, very important that evidence-based services are provided. And monitoring is a more general category that overlaps with everything. Just the fact that you keep your finger at the pulse as a responsible government and the social system, track how people are doing so that you can take measures when needed. So in a nutshell, this is part of the knowledge base we have for mental health and psychosocial support. But we can also see in these guidelines, which is very interesting, that there are some models and frameworks that play a role in them. This is a very important publication from 2007. These are called the 5 essential principles of HOPFOL. And well, the idea is that every package of service after a disaster should at least provide or promote a sense of safety, calming, self and community efficacy, social connectedness, and hope. The second model, which is very important, the triangle from the Interagency Standing Committee guidelines, which is a distinction in 4 different levels. And in the broad base of the pyramid is about services that are relevant to anyone, regardless of your health profile, basic service and security. And upwards, there are more focused services depending on your needs, varying from community and family support, focused non-specialized support, and for a limited group, as we know that most people are resilient, we have specialized clinical mental health care. A similar model comes from the Dutch guidelines. It's based on the circle model from Bertolt Gersons. And the idea is that all the services should be directed at the person in the center, the person affected by a disaster. Then we have a first rind or circle with family, friends, and peers, which is your own setting, your own inner circle, where a lot of your social support can be found. And if that's not enough, then you can use or benefit from a second circle with organized forms of support, key figures or leaders in community, supervisors at work. In the end, we have in the step care model, primary and community care, GPs, social work, and if necessary, like in the triangle model, for those who need it, you can get access to specialized health providers, psychologists, psychiatrists, and other specialists. The last model is what we call the parabolical model. It's the idea that in the end, we want to provide high quality services, but if you combine that with an attitudinal axis, here as shown on the x-axis, your attitudes towards affected people can be either more passive or more active. In the end, that's not a problem because you can, well, let's wait for a while, let's apply watchful waiting, which is okay as long as you don't fall below the threshold of quality. And that happens when you assume that everyone will recover. And the fact that you ignore that there are vulnerable groups who need special attention. That's on the left side. On the right side, well, being active and proactive and listening to what people need is very valuable, but not if you go too far and exceed that threshold on the right, where you provide things to people that they don't need, or actually are making problems worse by emphasizing too much on the potential psychological burden of a crisis. So this is all part of what you can call the international knowledge base of mental health and psychosocial support, which brings me to part 2. I'm doing my best to speed up a bit. Well, at the beginning of the pandemic, what you could find in the international literature was mostly based on concerns. And that leading authors on trauma-related mental health and disaster studies that expressed concerns in leading journals also that the COVID-19 pandemic has alarming implications for individual and collective health and emotional and social functioning. Already evident that the direct and indirect psychological and social effects of the coronavirus disease pandemic are pervasive, could affect mental health now and in the future. And also what I really like is this editorial by Horton in The Lancet, that the idea that it's not a pandemic, but more a syndemic, that it's a disease on a background of economic and social disparity, that existing vulnerabilities from a social perspective moderate the effect and make it more severe for particular groups who get affected. And well, if you look at the indications of mental health impact in the first month and year of the pandemic, we see a plethora of studies and reviews. Well, the thing is, recently, or at least a couple of months ago, there was a study in Nature that also pointed out that the amount of studies on COVID-19 was already uncountable. Not to say that it's impossible. Well, it is impossible to go through the documents in detail. I also experienced as a reviewer that I also read manuscripts of very poor quality And in the end, you can feel a pressure also from editors to get it published because it's a hot item. In the end, that's not good at all, of course, because then we're actually polluting the literature. And what I already mentioned something about the methodological flaws in disaster research in general. This also applies to COVID-19. Many papers are based on biased samples. They are cross-sectional. They lack proper controls and comparison group. They don't have pre-event baselines and other limitations, which makes it very difficult to draw firm conclusions about it. So we really should be careful with developing studies. They should be, of course, based on representative samples, repetitive, long-term designs with proper controls. Because in the end, if we don't design studies like that, it will be impossible to say something about a short and long-term impact of COVID-19 on human health. And currently, in the Netherlands, we developed this 5-year monitor, which is really a massive study based on thousands of municipal health region questionnaires and representative samples, and also registry data from GPs, international literature reviews. I don't have the time to really go into detail, but in the end, that is a way, I think, on how we can do it. What's recommended in terms of interventions and measures? Well, what I really think is good, that in the first months of the pandemic, in the first year, a lot of modifications were made to existing psychosocial care guidelines. And they were made rapidly available to different countries in the global south, in the global north. That can really, they did help us with planning services for affected populations. This COLA study from 2021 categorizes different recommendations about on the one hand for remote services on the left, in-person services on the right, and divided in 3 categories. I think that's the main image of this too rich slide. There are 3 categories of services, like health seeking and delivery of treatment, detection of psychological distress and mental illness, and mental health and psychosocial principles in the response. I think the best study I read so far is a review by Damiano et al., and they really delved into the literature to see what was recommended. They categorized it. Also, it's too much to comprehend if I show it like this in a limited amount of time. It's very informative because it distinguishes these categories, which are very much, the content is very much in line with what I presented earlier about the general guidelines. We have psychological and psychiatric interventions, complementary and alternative therapy, self-care, recommendations linked to technology and media, education, governmental programs, general recommendations, spirituality and religiousness, healthcare institutions, physical intervention. Well, this is actually the part I like most, but since I only have like 1.5 minutes left, I'll do it quickly. To make a long story short, if you go through the reviews, and this is rather sad, that the authors mostly conclude that the quality of the work they have to assess is not that good, which also makes it very difficult, even impossible, to draw firm conclusions about what to do and not to do. So, to put it simple, we have a tendency to formulate recommendations, and we want to formulate recommendations, but at the same time we are hindered a lot by the level of the evidence, the quality of the evidence. And we also see that reviews and also the source documents, the studies, contain little information on the working mechanisms and implementation conditions of the intervention studies, which actually hinders an effective broad uptake or scale-up of good practices to new events. And this is again the parabolic model I showed you. This is also to indicate we are looking at interventions and we want them to be informative about how to provide qualitative care, high quality care. And that means that we actually need information about in which quarter of the model is the recommendation evaluated? Did it address risks? Did it prevent things from getting worse? It's right in the right upper corner. Or is it something that lacked involvement of stakeholders and was not aware of people's needs, ignored interests, and came too late, as shown, for instance, in the left lower corner. So this type of information is really crucial to make a decision on what type of interventions do you want to recommend. What we don't include either is the fact that evaluation assessments, they reflect a moment in the timeline where the evaluation is conducted. So it matters if you are in T1, for instance, phase where there's a lot of support from every corner of society, the typical honeymoon phase, or that you're evaluating something in the T2 disillusionment phase where people feel ignored and not taken seriously. It's very likely that you will receive different evaluation findings and effectiveness results depending on the moment in the timeline. And another thing, everything what I've seen so far in epidemiological literature fits within the idea that the development of mental health and well-being over time is really linked to the severity of the social distancing measures, every measure government takes to mitigate the crisis and to make sure that the pandemic gets under control. Because this is part of a context where a society is being locked. You can see that the severity of the measures is accompanied by an increase in loneliness and a decrease in mental health and well-being. Well, these are hypotheses we can work for in the coming years to see whether it really evolves. We can also test whether in the end people are actually getting more resilient because they are used more and more to difficult circumstances, or that in the end they get less resilient because over time their mental muscle, as a metaphor, is getting tired. This is a final drawing. This is also to show that lessons drawn from one moment in time in a particular event, every block shown in this image is in fact a disaster in the recent past or a bit longer ago, different areas of the world. And I'm showing you just to illustrate the idea that you cannot just take lessons from one disaster microsystem in Bangladesh 1970 and apply it, for instance, to the Lebanon Beirut explosions in 2020 or Hurricane Katrina in 2005, and not even across the world in every affected country in the context of the current COVID-19 pandemic. This brings me to the final conclusions. Is the existing disaster mental health knowledge base applicable to COVID-19? I would say yes. I really have the feeling also when I look at conversations I had with colleagues in different countries that this existing broad knowledge base was helpful to structure, align our thinking and discussion within and between country borders. This also applies to the existing epidemiological knowledge because the incidence, prevalence and the risks and concerns in the literature are really helpful to give you more idea about what to expect in the COVID-19 pandemic. I also really believe that the existing guidance in the existing literatures was a really good starting point to rapidly produce more pandemic-specific recommendations, which was actually done, as I showed you earlier. I also think that the existing guidance was useful for the planning and delivery of support and healthcare interventions at collective and individual level. I talked to this about with colleagues in Austria, and I was also involved in the Netherlands together with the municipal health regions and the RIVM on planning the psychosocial support interventions in the Netherlands. And we borrowed heavily, of course, from the existing guidelines. So in that sense, I really believe it was useful. But the answer also has a no. And that means that the existing knowledge base is really based on different event types. Not about, we have little empirical evidence about the consequences and how to act when it's not a slow onset creeping crisis. Or I should say, we have little information on slow onset and creeping crisis that are mostly directly dangerous to vulnerable populations, especially the elderly. the existing knowledge base is based also on a different intensity of trauma exposure and less occupied with chronic uncertainty and stress. And what we also learned is that approaching mental health risks of COVID-19 from a psychotrauma perspective is problematic. There's a lively debate in the field of post-traumatic stress disorder that how you interpret criterion A, which has to do with exposure. If you are less strict in it, then it will dilute the diagnosis, increase heterogeneity. It makes comparison studies difficult, and it creates actually a new pool of people with varying degrees of risk and vulnerability factors that is very difficult to interpret. If you look in the literature, I have the feeling, that's an impression, that it leads to that if you use the existing knowledge base as a frame of reference, that it leads to an overestimation of the short-term population impact, and that you increase the risk of alarmist or activistic communication, which can be helpful on the other hand, because it also results into awareness raising, but we should be not too strict and not too alarmist if we really are not certain. And this is a typical problem, and I see this as one of the most important challenges we have in our field, that the effects of mental health measures and interventions applied in the COVID-19 pandemic are really unclear. We only know what is recommended. We can create overviews, we can map what was done, but what it really did, and whether it is positive or negative in the parabolic model, we just don't know. And the methodological shortcomings and universalistic nature of guidelines and recommendations that complicate the application of guidance in unique population contexts. So in the end, you really need to reinvent the contents of rather vague recommendations from general documents into the context where you are working yourself. So that is my last slide. It's actually not. I want to thank a couple of colleagues who provided necessary input for my talk today: Hans ter Brake, Vera van Hoof, Charlie Steen, Lisa Eileen Stene, and Andrea Williams. Because, without their help, I would not have been in a position to give this talk the way it is today. Thank you for your attention.